Good morning, everyone, or good evening, depending where you are. Can you all hear me? Please tell me in the chat. Yes, perfect. So welcome to this webinar. Today we have Dr. Carlos Naval as a guest, who will explain to us how his practice has changed during this pandemic era. And we are very glad to have him today. I will give you just two information about the webinar. If you have any trouble with audio or video, you have a reconnect button in the top right side of the screen. So just click there and you will be brought back to the webinar. All the questions will be answered at the end of the presentation. You can leave them in the question section that is below the video, because if you leave them in the chat, we may miss them. So it's more comfortable if you leave them there. And now I will let you to enjoy the webinar. Please, doctor, take it away. Doctor, for your presentation.
Okay, can you hear me? So what we're seeing here in Manila is that probably the same thing in your countries where you're on lockdown or some enhanced, we call it here an enhanced community quarantine. We're not allowed to do, on the medical side, elective surgeries. We only see patients on an urgent case basis. And usually that's in the emergency room of a hospital. They are planning to lift the quarantine on May 15. We may actually apply for an earlier an exemption in the Philippines because we're a healthcare provider. We run an ambulatory surgery center, and most of the time we do cataract surgery, so mostly elective procedures, which I'm sure that's probably the same in most of your cases. Now, the thing is, when the COVID actually disappears, it's not going to go away completely unless somebody develops a vaccine very soon, which is probably not going to be available for, I think, 6 months to a year. Just like the other viruses, like influenza, it's probably going to stay in the community, maybe come out with at intervals of epidemic or small epidemic outbreaks, and you have to quarantine some people. Hopefully we can test them very well so we can sort of reduce the number of people who can be locked down or quarantined. Now, the lockdown or quarantine has been proven to reduce transmission and the rate of contagion, but it does not confer any immunity. So herd immunity, which is actually what we're hoping for, will probably happen when many people had been infected, and if those patients who had been infected and survived have actually developed some sort of immunity, then they hopefully do not transmit the virus anymore to other people who are still not immune. Other thing is, if many in the community are already immune, then that means the virus cannot jump easily from person to person. Now, the advantage of the lockdown or the quarantine is that it pushes the peak or flattens the curve to the right. This is our local curve where you have the yellow, orange as the number of cases. And we see a sort of reduction in the doubling time of cases. So the more, unfortunately or paradoxically, the more successful your quarantining is, the longer before you reach a peak, because that is actually the what you want to do. You want to reduce that curve. So that means that when we open, if we're allowed to open, the virus is still going to be in the community. The Philippine Society of Cataract and Refractive Surgery has come out with a manual, Restarting After the Enhanced Community Quarantine, which outlines some scenarios or some helpful tips about how to restart your clinic in the post quarantine scenario where you actually still have probably some asymptomatic transmit patients who might transmit the virus, or we ourselves could be transmitting the virus to our patients. And since we usually treat the geriatric population, they would be at most risk of developing worse symptoms, and also the more likely to die from the disease. So we produce this guide for our patients, which we will give out when they come to the clinic. So it's probably not going to be true that we're going to be able to go back to what it was before the COVID. We probably have to wear some degree of protective equipment. Again, depending on the guidelines in your country, you may have to wear goggles or face shields. You may have to wear N95 mask or some equivalent protection. Then, of course, the usual sanitation of hands, sterilization of instruments between patients will probably be more important, and probably some degree of physical distancing. So, physical distancing meaning you can't pat the patient on the back, you can't hold the patient's hand. You probably have to wear gloves or some other protection, maybe use swabs when uh, touching their lids or putting their eyelids up or down. You probably have to reduce any instrument that has contact with the patient, probably put face shields on the slit lamp. But I think wearing so much protective equipment during consultations is an unsustainable um, practice, because we probably will start relaxing our guard once we're in maybe 2 weeks into the practice. Maybe you'll find it uncomfortable, unnatural. It will also add overhead costs to our operation. So I suspect that we may start doing shortcuts, maybe not wearing the face shield anymore, maybe just washing hands, maybe still touching the patients occasionally. So what are we actually to do? Well, of course, there's always teleophthalmology, but it has its limitations. Uh, some who have tried it have shown that if their light is not good, your internet speed and accessibility also can suffer based on your connections, and you still need technical support. Of course, it's very good if it's aided by artificial intelligence, but it's still on the patient side, even if you're not there. It has to be performed by an optometrist or a technician handling the equipment. So you actually reduce the risk on your end, but you shift it to someone else. So the technician becomes the person at risk from the patient, although you remove the risk of you yourself passing it to that patient. It does reduce travel time for the patient if you have remote access or a place where you can be, uh, patients can go to that remote area without much travel. You cannot, however, probably perform diagnostic maneuvers that require some manipulation or, of course, surgical procedures. So I was thinking maybe we should probably start shifting to contactless ophthalmology. That means compartmentalized patient handling. You have to revamp or rethink your clinic design. You probably have to design some cubicles or some areas where you have complete separation of the clinic staff from the patient. So just like in a bank, maybe, or in a traditional bank where you have tellers or windows, the patient is guided from window to window. I don't know about in your country, but most of the time in our country, when you have visa applications, there's hardly any personal contact. There's usually a barrier between the interviewer or the processor and the one applying. So it probably is going to be like that, and minimal contact with the patient. That's what I foresee that we'll end up doing if we want to keep um, being the instruments for transmitting infection. Although COVID is the one that has come out now, and it may disappear with, let's say, vaccination or treatment, it's probably not going to be the only one. So there's probably going to be another virus eventually in a few years. So I think we should start learning from this experience. Now, there's technology that we can use. This is, of course, nowadays enabled by computerization and paperless transactions, such as electronic medical records, you have cashless payments, and advanced equipment where you don't have to manually handle each aspect of the procedure. One example of this is Adaptica's Twin. Here you have a refractometer and vision analyzer, which you can perform at a distance, even 6 feet or 2 meters, whatever the social or physical distancing that is recommended in your country. You can imagine here that through a barrier or even a barrier with the twin there, you can actually do your refraction with the patient far away from you on the other side of the barrier. Now, the Kaleidos is another technology that allows automated measurement. So you actually can be on one side of the barrier, looking at the patient and giving patient instructions about how to use the equipment. So you have binocular refraction, monocular refraction, pupillary distance, pupil size. You can see if the head is tilted. You can check the direction of gaze. You can therefore diagnose phorias and tropias, and very fast and very accurately. So even in children, this is what they designed this for. But I think with our COVID situation, I think this is a very good thing to adapt. So you don't need an automated refractometer where the patient has to put his chin on a chin rest and put the forehead against the strap and have a technician there to push buttons, because this one is controllable with an application or an app that is on Huawei or Samsung Pad. I think that's what Adaptica recommends. Now, of course, the Adaptica Vision Fit SC is the headgear that can replace the trial frame and the phoropter. So you just have the patient wear it on his head. He can see a chart through the lenses, and the lenses have adaptive lenses, and you can simulate whatever refraction you got from the Kaleidos. So you can do subjective refraction. And again, it's app-based completely. So you can also integrate it with your electronic records. Now, electronic charts are everywhere. So if you prefer an electronic chart, Adaptica has the Aquid chart. It's an HD LED monitor. The difference is that it has more charts. It's dynamic and interactive. And again, it can be controlled by a traditional remote control or using the Aquid app. So you have a working distance for the full LED monitor of 2 to 8 meters. And you also have a mobile version where the patient holds an app either at 0.4 meters, or you can even have somebody put it at 5 meters when you're testing. So what I dare you to do is to reimagine. So instead of you having a patient right in front of you in the slit lamp, you have this barrier between you and the patient. Similar, as I said, to a bank teller, or similar to visa application, where there's probably a device where you can hear each other, but there's something that prevents droplet or aerosol transmission, and probably some independent air conditioning system. What I wish Adaptica would do is do something like slit lamp with no optics, and this is not really impossible. We have, I think you've seen some of you may have seen the Artivo from Zeiss. where the operating microscope is now free from optics. So you can see everything on the monitor using a very low light video camera. And you can use 3D spectacles to see the image in 3 dimensions. So the same thing happens with the ingenuity of Alcon. And I think if Adaptica or some other company puts its mind to it, maybe they can do this with a slit lamp and probably be able to give us some controls, a joystick or something where we can control the movements of the slit lamp X, Y, and Z. So maybe even change the focus or use an app or a computer to change magnification. So again, you can have the slit lamp on the side of the patient, and you can be behind the barrier instructing the patient on what to do. The other thing that we were going to use Adaptica for before the COVID came around was actually to create a mobile eye clinic because of our worsening traffic situation and some invalid patients. Patients have a hard time going to the clinic because of problems. They're bedridden or they're hooked on oxygen tank because of some pulmonary problem. This set of instruments, I think they call it their refraction set. You have the Vision Fit, you have the Kaleidos, and you can actually do refraction just using these instruments, which can fit in a briefcase that they give you. So even the Kaleidos can be folded, so you can actually bring it around. So this is what actually I think will eventually be what we go to, redesign our clinics for 2021 or 2020 beyond this experience of the pandemic to prevent further pandemics or to reduce another surge or a surge from reinfection. So instead of an open clinic where everybody mingles around and you have the patients very accessible through the clinics, you probably have something like a window where you have a device that actually separates the doctor or the nurses or other healthcare providers from the patients. Of course, with emergency access or access when you have to actually touch the patient and probably use protective equipment. But this is, I think, a more sustainable way of keeping that physical distance and reducing transmission without wearing all the gear that you have to change and probably discard every day, if not after every patient. Well, the other thing, this one I just threw in because we were starting to think about the future. I was thinking of the future of IOL technology. Probably it's going to be biometry, aberrometry, OCT in one machine. Then you choose your IOL based on the functional vision that you want to give the patient. It's thrown up to the cloud. The cloud gives a proprietary plan and throws that proprietary plan based on your choice and the IOL power to a 3D printer that sits in your office. And the 3D printer prints the lens, which is then polished and packed. And you can sterilize it in a plasma sterilizer and ready for surgery the next day. So that's just something I threw in just if somebody else is interested in developing that. So in the end, as Peter Drucker says, the future is really very hard to predict. And the only way probably to predict it properly is to actually help create it. Thank you very much.
Now, if anybody has questions, please leave them in the question section. If you need more commercial information that are not related to the presentation, just go to the website adaptica.com and refer to your local distributor. You can find information about that still on the website. And now we just wait if anybody has some question. Oh, we have one. Jamie is asking, separation will be difficult for surgical procedures.
Yes, that's true. Until we get into robotics, I think that's quite close to impossible. But you see the advantage of surgery. Operating rooms are almost segregated, except during surgery, you have a patient who's fully gowned. You have a surgeon who's also fully gowned. So all you have to do is probably gown early and include the patient in putting PPEs or putting N95 masks. So I'm not so worried about the operating room because we already usually have some laminar flow, already have some degree of sterilization, you have ultraviolet light, etc. So it's quite difficult actually, I think, to transmit the infection during the surgery. It's during consultation where we're so used to being very casual, sometimes depending on probably your custom, or your culture, very touchy-feely with the patients. That's probably the point where you have more transmission. The operating room, you have masks, you have probably goggles, you probably have sterilization in between cases anyway. So I don't think that's a very big problem.
We have a few more questions, Doctor, if you scroll down in the question area.
I think some are comments. I can't answer about when they'll probably be available in the market. I'm not sure it's easy to add face shields to surgery unless you're not going to use the microscope. That's why an optic lens, if we have equipment where you're not so dependent on looking through the optics, then maybe we can use face shields. But face shields, if they're not of good quality, can also distort, give you some distortion of the image. I've had colleagues who actually complain that they get dizzy after some time of using the face shields. So hopefully Adaptica helps us in continuing our clinics post-COVID, and I'm sure you'll find their equipment in the right configuration for this barrier or contactless ophthalmology. Okay.
Okay, so if we don't have any more questions, I think it's time to end the webinar, and thank everybody for joining, and thank you, Doctor, for accepting to attend the webinar with us. For everybody who has any more questions, it was an honor to have you. Thank you a lot.
Thank you
for
for the
anybody
invitation.
else who has more questions, you can write at webinar@adaptica.com. As I said, for commercial information, refer to your local distributors. Also for promotion that may be ongoing now, like the spring promotion that I leave you here, you will be able to click now. And I wish you have a very nice day or a very nice evening, depending where you are. And thank you very much for attending. Bye, everyone.